Good morning, everyone. Welcome on behalf of the African Global Mental Health Institute. I'm Michelle Durham, a child and adolescent psychiatrist at Boston Medical Center and assistant professor of psychiatry at BU School of Medicine. I'm happy to moderate this excellent panel today with Dr. Bonga Chiliza. Dr. Chiliza is an associate professor, chief specialist, and chair of the Department of Psychiatry at the University of KwaZulu-Natal, and also the president of the South African Society of Psychiatrists. Briefly, the AGMHI's vision is to equip those in Africa and the diaspora with the tools and agency to effectively care for those suffering from mental illness by fostering collaborations, creating accessible training and education programs for both providers and the public, conducting and disseminating culturally relevant research, and identifying stakeholders to advance mental health care in Africa and the diaspora. I'm pleased today that we have psychiatrists across the diaspora from Kenya, Durban, Cape Town, and here in the US. Dr. Pamela Collins is a professor at the Department of Psychiatry and Behavioral Sciences in Global Health at the University of Washington, and also the Executive Director of International Training and Education Center for Health. Dr. Lukoye Atwale is the Associate Professor at the Department of Mental Health, Moi University School of Medicine, Consultant Psychiatrist, Teaching and Referral Hospital. And Dr. Anusha Lachman is a child and adolescent psychiatrist and infant mental health specialist, a program convener at the Department of Psychiatry at Stellenbosch University. As always, we're going to start our panel today with a few questions for each of our panelists. We encourage you to use the Q&A function to ask other questions of the panelists. Dr. Chiliza will then do some of those Q&A questions, and that we hope that we have a really lively discussion towards the end, giving more time for all the questions you may have as we discuss Black Lives Matter, racism, and mental health in the context of COVID-19. With that, Dr. Collins will be providing some opening thoughts on the compounding effects of racism and COVID-19 on the mental health of Black people in the US. Dr. Collins.
Good morning. Thank you, Dr. Durham. It's a real pleasure to be here. And I want to start with a little bit of history and remind everyone that what we're seeing today is a part of a long history of centuries in the United States, that the story of Africans in North America has been marked by struggle, by successes and advances, repression, struggles, successes, an ongoing cycle that we still experience today. Africans have been in what is now North America since the 1500s, first with Spanish expeditions in the Southwest and the Gulf Coast, and then brought to the English North American colonies from around 1619 and onward. The 1600s is when slave traders decided to base the American economic system on human slavery based on skin color. Virginia and Maryland were the first colonies to enact laws that made Blacks slaves for life. Fast forward, after 2 centuries of this same cycle of struggle, advancement, repression, struggle, successes, failures, this ongoing cycle, slaves were emancipated in the 1860s. Around 100 years later, the passage of the Civil Rights Act and the Voting Rights Act end legal segregation, but do not establish racial equity and social justice in the society. So against this backdrop, Black Americans experience persistent cultural and structural racism in their encounters with healthcare and with science. So when we come to the 20th century, probably one of the events that's most widely known is that African Americans were exposed to harmful research and treatment practices through the Tuskegee study. This is where Black men were deceived, not consented, and denied treatment in order for investigators to study the natural course of syphilis. But many routine experiences of differential treatment compared to whites have reinforced this mistrust of the healthcare system and its institutions. Ethnic minority patients receive less information, less empathy, less attention from their physicians regarding their medical care than do their white counterparts. So that gives you a little bit of the larger social context. But what about our mental health? So our data from 2017 from the Substance Abuse and Mental Health Services Administration tell us that around 16% of Black Americans report any mental illness in the last year. And that's not significantly different from white Americans, and actually a bit lower. But fewer than 1/3 receive the care they need. African Americans tend to receive mental health care when mental health problems are more severe. Interactions with the mental health care services tend to be complicated by social stigma, by mistrust of services on the demand side, and lack of access to quality services, as well as culturally competent providers on the supply side. Now comes COVID-19. And this pandemic has generated tremendous need for mental health supports, whether through self-help or existing social networks or through professional services. And I want to talk about 3 reasons why this is so. So first of all, COVID is disproportionately affecting Black people in the United States. Rodlisha Sneed and her colleagues have published a very helpful case study on African Americans in the state of Michigan. In general, Black people are witnessing a disproportionate number of hospitalizations and mortality due to COVID-19 in the United States. And if you take the state of Michigan as an example, Black people make up 13% of the population, 31% of confirmed COVID-19 cases, 41% of pandemic-related deaths, and more than 10% of cases in African American communities in Michigan have ended in death. Number 2, this pandemic, has shown a light on long-standing structural inequities. So economic inequities are reflected simply in who needs to leave the house to work during this time. How do you get to work? How many underlying medical conditions do you have? And these are more prevalent among Black people as a result, in part, of the same long-standing health disparities and other inequities. So COVID-19, I think, further challenges the Black community. Our understanding of the virus and the best approaches to preventing infection have unfolded as people have witnessed their friends and family members become infected and die. And the political divide over whether to promote science-based public health messages then has another meaning, de-emphasizing the need for the public to take appropriate precautions devalues the lives of those who are disproportionately affected. So this includes Black people, it includes the lives of the elderly, Indigenous groups, and others. The third point I want to make is that fear and grief are expected responses. African Americans are twice as likely as whites to know someone who has been hospitalized or who has died from COVID-19. So there's a vicarious trauma that people are experiencing in this context. And I want to just call out Derek Novacek and his colleagues at UCLA, who've done some really nice work on the mental health ramifications of COVID-19 for Black Americans. And we can put that resource in the chat later on as well. But fear of contracting the disease due to fear of racial bias in testing and treatment is another driver of distress right now. So what happens if you get sick? Will you get life-saving assistance if you have severe disease? I think these are questions that Black people ask. Will someone with co-occurring medical conditions be less likely to receive life-saving care if resources are short? If you're already unsure that the medical system is on your side, these become really compelling and worrisome questions. Stress and grief have accumulated as people experience more losses. So this is what COVID-19 has brought us. I want to come to the police. So if things couldn't get worse, while under lockdown, the murders of Ahmaud Arbery, Breonna Taylor, and George Floyd further emphasize the pervasiveness and the mortal danger associated with racism. Jacob Bohr and his colleagues in 2019 reported on the spillover effects of police killings on the mental health of Black Americans. Black Americans are nearly 3 times more likely than are white Americans to be killed by the police. We constitute more than 40% of victims of all police killings nationwide and are 5 times more likely than are white Americans to be killed unarmed. So in addition to the suffering experienced by the victims of these shootings and their immediate families if they survive. Police killings also affect other Black people vicariously. And how does this happen? Well, they intensify our perceptions of systemic racism, lack of fairness, loss of social status, fear of victimization, anger, communal bereavement. And we already know that race-based discrimination can negatively affect mental health, of course. So exposure to discrimination is related not only to symptoms of mental illness and of distress, but also to defined disorders, as well as preclinical indicators of other forms of disease, the chronic diseases that we started this conversation talking about. There's at least one longitudinal study from the UK that shows a dose-response relationship between cumulative experiences of discrimination and deterioration in mental health. And David Williams and his colleagues have a wonderful review of the effects of race-based discrimination on mental health and other medical conditions that came out in 2019. So what Bohr and colleagues showed in their analysis was that every additional police killing of an unarmed Black American was associated with 0.14 additional poor mental health days for Black people living in the same state. So at a population level, police killings could contribute 1.7 additional mental health days per person, or when you look at the Black population in the United States, we're talking about 55 million excess days of poor mental health per year among Black American adults in the United States. And that same effect was not seen among the white population studied. So how do these shootings get under the skin, they ask? And I want to just reiterate it. These heightened perceptions of threat, vulnerability, lack of fairness, lower social status, identifying with the person who was killed, and activation of prior trauma. So all of these have been concentrated in these last few months. And so this gives us a sense of what's happening in the United States right now. Thank you.
Thank you so much, Dr. Collins. This gives a segue to go to Dr. Atwali on describing a bit of the African experience and really drawing parallels from what Dr. Collins mentioned, specifically around the Black Lives Matter movement in the US and thinking more about the protests against ethnic discrimination in Kenya.
Yeah, so thank you very much. And I'll pick up from where Pamela has left off. And I think she's framed it very well from a historical perspective up to the present day. And you would be interested to know that there are many parallels between what is happening to minorities and Black people in the United States and what has happened historically in this country. Initially, before the 60s, most of the continent was under minority rule by colonial governments from Europe. And in Kenya, it was the British that were in charge. And this culminated sometime in 1959 in a massacre of people who had been kept in a concentration camp, in one of the concentration camps where able-bodied men would be locked up and made to do labor. And so when they protested in 1959, a number of them were bludgeoned to death. And this brought it to the awareness of the UK Parliament and the wider public, leading to calls for independence and majority rule. And so in the early 60s, then the system of government changed. We got independence in Kenya in 1963, and in 64 became a republic with our own president and leadership. However, what happened was that for all intents and purposes, there was a replacement of the colonial elite with a local elite, and very little else changed. And so the discrimination against poor people was particularly marked, and it was almost official policy that investment would go to areas that had higher potential in the country at the expense of those that were considered to be low potential. And these areas were then mapped out almost in an ethnic pattern. And it was the beginning of subsequent perceptions of ethnic discrimination against some people or some areas, and overinvestment in some other parts of the country. This continued through the 60s and the 70s. There was a change of guard when the first president died and the second president came in and attempted to try and shift some of the resources to the ethnic areas where he came from. And again, so other communities were considered to be in the opposition, if you like. And so this continued until the early 2000s, when the protests against this system of governance, this cronism, this nepotism, this tribal-based resource allocation culminated in political protests across the country against this kind of system. And in 2008, there was particularly serious ethnic conflict after an election which was perceived to have been stolen in order to perpetuate the same kind of system of governance. And after that conflict in 2008, where hundreds of people were killed, then we changed the system of governance. There was a new constitution that was enacted, and it attempted to start redressing those historical injustices and historical discrimination by making it, splitting the country into counties and trying to bring governance closer to the people and trying to ensure more equitable allocation of resources. We are still learning from that. And as we are still learning how to do that better for the people, then COVID-19 strikes. And this has been particularly difficult, looking at it from a mental health perspective. Initially, some of the work I have done on the Mau Mau survivors, these were the freedom fighters of the 60s. We found in as late as 2006 that about 2/3 of them had PTSD or significant symptoms of PTSD. And in Kenya, the mental health system has not been much to speak of. And COVID-19 therefore exposes these disparities even more, that it has increased the risk of mental ill health, but with a dilapidated system that's continuing to crumble. So we are identifying a greater need in this time. And now moving on to mental health most substantively, just before January this year, sometime in November, December, the government set up a task force to look at mental health after all these things have happened, to try and suggest what needs to be done to improve the mental health system in the country. And coincidentally, as we entered, the take-off point in the numbers of people affected by COVID-19, that's when our report was ready and was handed into the minister. And so the implementation of this task force report has been tied in with the COVID-19 response. And the government seems to be committed to implement it and ensure that after this pandemic, the mental health system should be better and better able to handle whatever we're expecting is coming. Some of the risks that emerged from this response was that in the beginning, as the government set up mechanisms for control, including movement restrictions, curfews, and so on, there was use of excessive force based on the history that I have just said, that government would use force in order to implement whatever government directives were in place. And so the police used excessive force to try and make people comply. And we argued that this made things worse because it didn't help at all with infection control, because people were huddled together, people were all over the place, and it didn't help much. But also it increased resentment against the health measures that had been put in place and made it that much more difficult to have the public trust the public health system and to adhere to the recommendations that would be made by the health sector. Then came Black Lives Matter. The average urban Kenyan is very globalized in their perspective, and they're very vocal about social justice and politics globally. And so when things started happening in the US and people started seeing a perception of discrimination, it was I think, brought closer home than the anecdotal stories that we have been talking about. In the US, every once in a while you get these things happening, but it was all brought together in very stark manner. And it became a subject of conversation in Kenya, in Nairobi. And in fact, civil society in Nairobi organized protests outside the American embassy, even during this COVID-19 times. So it's a pretty complex situation where we are affected by what is happening in the US, what's happening in Europe, but we're also affected by intrinsic inequalities that are already here, that were established in the colonial days. And so we feel doubly affected in that way. But then we feel like we have a little bit more urgency, in the sense that some of the things that need to be done, we can do them ourselves without necessarily waiting for an outside force to do that. So thank you very much. That's where I will stop.
Thank you. I'm sure there'll be more questions to come. Thank you both for setting that framework of what's happened historically across the diaspora. I think that, we've invited Dr. Lockman again because we also want to remember the kids throughout all of this that are seeing all the adults and all of this happening on TV and in the media and in our lives. And so if you can describe a bit about children's awareness of race and provide resources on how to approach some of these conversations about racial inequities with young children.
Great. So thank you for the invitation. I guess we should start at the beginning, which is that we have a really popular belief, which is largely untrue, that very young children are racially colorblind. But here's the thing. Research shows that children not only recognize race from a very young age, but they also develop racial biases by ages as young as 3. In fact, infants are able to non-verbally categorize people by race and gender as early as 6 months of age. So we know that infants can look significantly longer at an unfamiliar face of a different race than they do at an unfamiliar face of their same race. And so if we think about it, toddlers as young as 2 use racial categories to reason about people's behaviors. And then they don't just categorize people by race, but also express bias based on race. And this is called stereotyping. So stereotyping is a very typical feature of an immature cognitive structure of the brain of preschoolers. And when young children are able to categorize people by race, they often can't distinguish or actually categorize according to multiple dimensions at the same time. So they engage in largely what we call transductive reasoning. So when they see people who are alike in one dimension, so for example, if they see a person of particular skin color, anybody that they see who looks similar will be presumed to be alike in other dimensions as well. So they will typecast according to abilities or intelligence. And the problem with this is that this is influenced by socially constructed attitudes, by societal norms, by exposure to systemic racial bias in the media. So what I'm saying is, if we as young as a preschooler have to recognize that their introduction to the world is really characterized by the things that divide us, so things like ethnicity, gender, physical ability, and race, when they start really the formative years, simple things like the difference in hair texture or the color of their eyes or their skins, children discover that difference amongst their peers. And they share that with the world around them. The problem is that the biases that adults convey, so this can be positive or negative, things like this person is safe or this person is more beautiful than the other, all of those imply that these conversations about race and racial attitudes really need to start in the home very early on. And so the next question is, what's the right way and when to do it? I think we have to remember there's no right one single way to talk to children about race, but it really has to be more about more than just a single conversation. The most consistent message, if you look across the literature, is to talk about it. We often rely on silence. So it's very clear that silence about race doesn't prevent children from developing racial biases. All it does is prevent a conversation about racial biases. So the next thing is to ask yourself, how do you talk to children about race? What should you do? And I thought about it, and perhaps there are about 4 kind of tips I can think of. The first is be honest. We don't want to step into the mistake of encouraging children to be colorblind, or we don't want to tell children, look, everybody's the same. We're just one human race, because the reality is it's not true. Children do see color. And we all have biases on how we view other people. So when it comes to race, particularly, biases are quite negative when we think of people of color, particularly brown and Black people. So rather, what you want to do is to discuss differences openly. You want to highlight diversity. And how you do that is simply by engaging in platforms that encourage that diversity. So that would be, how would we talk to young children to teach them about life, about animals, about all kinds of things? We usually use books or toys or TV shows or games. And so I would suggest that you look for similar games, books, TV programs that feature diverse characters in a positive, non-stereotypical roles. So I have shared a list of resources which you will get if you haven't received already, which gives you an indication of the kind of books that are available. But in fact, you just need to Google it, showing characters that are positive and non-stereotypical. And we see it all the time. If you think of television shows that young kids watch, if you look at Doc McStuffins, a really, really good example of how a simple TV show can encourage gender stereotyping to be dismissed. So we have a stay-at-home dad and a doctor mom and a Black family who is viewed in a really positive, intellectual society rather than just the usual that we are able to dismiss. The next thing is to think about being accurate and age appropriate. So conversations about race can't be diluted. When adults often discuss race, if they do at all, they often feel that young children don't understand the complexities of the issue. And so what happens is we dilute the discussion. And so you get this really superficial kind of attempt at discussing education that focuses only on celebration of culture. So you might say, oh, look, this is a really clever brown girl who's got a Nobel Prize, or look at this really smart and successful Black girl who's an Olympic gymnast. And that's great. But what that actually does is leaves out any discussion of structural inequalities and inequities. And you can see what the challenge with that would be for children who only get presented with one side of how successful people of color can be without actually hearing that things can be really hard and difficult to achieve. The next thing I would say is embrace curiosity. Parents, therapists, adults are often very scared because the questions children ask make you uncomfortable. So you need to be careful not to ignore or discourage a child's question, especially when it comes to differences. Because if you're not open to those kind of questions, the message that gets sent is that the difference is negative, and so we don't talk about it. And finally, perhaps the thing that should come as no surprise is you have to lead by example. So if you ask yourself, what does my circle of friends look like? What do the acquaintances look like that my child sees me engage in? If you want your kids to successfully create relationships with people that are different, you need to be seen to be doing that. So another thing we talk about in infant literature is mirroring and modeling. Children learn through mirroring what the adults around them do in terms of responses, in terms of inclusivity. So when you see something, say something. Children will learn to do the same. This may mean that you have to call out a relative that might say some racist joke, or a family member that makes some disparaging comments. Something as simple as if a child goes to a school that's really fancy, or private schools like we have in South Africa, where predominantly the white staff makes up teaching staff and the brown or Black people are the cleaning staff. This is a conversation to have. Why is that? Not just a conversation with school boards and with other parents, but with children, to be able to recognize that people sometimes find themselves in positions where they aren't able to get out of to progress, and why that is important for a child to understand. So again, remember, children observe and learn from parents' interactions, from what is not said directly to them. So I guess in summary, what we're saying is you are the example. How you talk to children will be determined by how you behave. What they see you do is as important as what they hear you say. And like language, prejudice is learned over time. So in helping your child recognize and confront racial biases, you first have to look at yourself and your own. What does your circle of friends look like? Who are the people that you work with? What kind of relationships do you have? Are they a diverse and inclusive group? And then take each opportunity to challenge racism and to demonstrate kindness. You may not have the answers. Sometimes that's what children need to hear, that we don't know why things are so unfair, but acknowledging that it isn't just as it is for everyone of the same race group. And I guess in conclusion, just to say that, about timing, the time is always right to do right. And that's about it. Thanks.
Thank you very much, Anusha, and thank you very much, colleagues, for I really thought were very thought-provoking intros to the discussions, and I just want to call upon the participants to now start using the Q&A, please, to post your questions to any of the panelists, and then Michelle and I will read them out and ask the panelists to answer them. So maybe I can start with you, Dr. Collins. Pamela, really thank you for some interesting thoughts. My first question was about trust and what you've said about trust. And I was wondering, as psychiatrists in the US, or perhaps I think probably also in Africa, how do we build trust with our people? And knowing that there's all these multiple layers of trauma and different studies like the Tuskegee study that you've mentioned and other things. How do we build our health systems, our mental health systems, to try and improve the trust levels that we have with our people, with our patients?
Yeah, that's a great question, and I think it requires there's so many. There are multi-level interventions that need to happen to answer that question. I think one of them is first educating communities about mental health, about what does it actually mean if you have to go to services? What happens in these services? What should happen? And I think to let people know and to both explain to people who need mental health care, but also work with providers so that care really becomes user-centered, right? That this becomes a relationship of mutual respect, a relationship in which one knows, when I talk to this person, I'm not going to be told such and such and such. I'm going to be listened to. They're going to try to understand my point of view, my perspective. They're going to listen to my explanation of what I think is wrong with me, what I think is causing me distress. So first of all, that enabling people to see that these can be safe relationships where they are listened to, where their point of view is understood. And of course, our field has a bad history, right? We have a history of coercing people, of taking away people's human rights, of placing people in really unpleasant places when they're at their most vulnerable. So we have a lot of work to do in terms of educating people about what care should look like, equipping providers to be able to provide that sort of humane, user-centered care, and then the work of transforming our health system so that we can ensure that when a Black person goes for care, what they're going to get is quality care, and they're going to get care that works, right? I mean, that's the other thing. People begin to trust the system when it's effective for them. So I think on the services side, those are some of the issues that those are some of the steps that we can begin to take. On the community side, we really have to have open conversations about mental health and mental illness, about what it means to protect and to build and to promote mental health, and what it means to get care that's needed when you have a mental illness, and explaining to people that this is not a character issue, this is not something to be ashamed of. And in fact, this is the time for empathy, this is the time for support, and this is the time to be able to expect people to respond to you appropriately.
Thank you very much. Dr. Collins, I also just wanted to ask you, as a public health expert, what were your thoughts when you saw the riots happening? Obviously, this was an incredibly urgent thing to be done by African Americans, by other people in America. But in this time when there is a pandemic, how did you kind of start to discuss some of those issues around the pandemic issues, and also obviously there's an urgent need for us for people to go out into the streets and really demonstrate their anger against the police brutality?
Thank you for that question, Bonga. I think I probably felt like a lot of Black people in the United States. First, the sense after seeing, these news reports, we know these things are happening. We know that the police brutality, we know this is happening even when it doesn't make the news, right? But I think everyone is already stressed out because of COVID, right? Everyone's stressed out because their movement is limited, and there's just this layer of uncertainty about what's happening. There's a layer of uncertainty for most people around jobs, around the economy, around everything is unstable. Our institutions are losing money. There's just that sense. So on top of that, to then hear all of the news, right? All of the news around these three very prominent killings. Certainly for me, it made me feel angry. It made me feel sad. It made me feel a pit in my stomach. And then finally, after the George Floyd killing, that was painful for me, but also because everyone began to erupt with this. I and other of my colleagues began to receive complaints, emails from people, right? What's happening? We need help. Students, people in our university context, people began to speak up about their own needs for attention, their own needs for help, the fact that we need to do something. And then I think, in addition to dealing with my own personal feelings, I needed to begin to think about how does one respond on an institutional level with colleagues to help people manage what they're seeing every day, to help people manage their own anxieties during this time. So it's been an emotionally intense time and it's hard to verbalize all of this. I mean, this is what we have to learn how to do, right? Is verbalize what we're experiencing, share what we're experiencing with each other, be willing to be vulnerable and say that, yeah, you're experiencing this, but so are the professionals. We're experiencing the same kinds of challenges because this is a really difficult time. I think the protests, certainly, I'm here in Seattle, and we had peaceful protests that turned violent towards on the first day or so, but then we've had a very, very persistent group of people protesting, and I would say one of the most rewarding moments was my husband and I, many of my colleagues and friends went to a protest organized by two of our faculty members, Estelle Williams and Edwin Lindo, for healthcare and public health providers. And there were, I think the estimate was 7,000 to 10,000 people showed up wearing masks, socially distanced to the best that we could. But it was amazing. And and I think that's been the other side of this. Yeah, there's the despair, the anger, the anxiety, has also been accompanied by a sense of being able to take some kind of organized action, right? Organized peaceful action, enabling people to read out their demands, enabling people to then open conversations with local leadership around these issues. So that piece of it, I think being able to say, wow, how can I get engaged in beginning to make changes? We've also, that's healing for me. That's a piece of the healing in the middle of all of this, is to say, what can I begin to do? I think the challenge for a lot of people is to decide what to do, right? One can also feel overwhelmed by all that's happening, right? So how do you decide what to do? And how do you also recognize that this is a long game? This is not, we get all energized for a month. This is going to be a long journey that I think people need to pace themselves. So remember to pace yourself, find what's doable. And everybody's response is going to be completely different in terms of how they participate. But that is the way social movements happen, right? You find your place and you figure out what your role is, and you don't think that you can do everything, and don't exhaust yourself in the first week, but recognize that this is a long game.
Thank you very much, Pamela. Lukoya, can I move to you here in Africa and just ask you, some of the people have criticized some of the outpouring of the response to Black Lives Matter, and saying that why is that in Africa there's this outrage for African Americans who are being killed in the US, when our own police are also brutally murdering poor Africans. Definitely in South Africa that is happening. I'm sure in Kenya as well, and other countries on our continent. How do you respond to that? What is the?
Yeah.
How does it start to engage people on that issue?
I don't think there's an easy answer to that, but I think most of us on the continent have operated on the assumption that in the background there is violence against African Americans and Africans in the diaspora. We have operated on the assumption that that is something that is already happening, and we have followed the history from Martin Luther King Jr., Malcolm X to Obama and so on. We followed this very closely, at least here in Kenya, in Nairobi. But then I think the internet has made it even more present. The internet has brought it home in ways that the traditional legacy media could not do. And in a way, we have been transported to the streets of New York and been part of the violence and experienced the pain as this is happening in the US and in the other cities. We have been made to be part of the protests. When people are demonstrating in the streets in Philadelphia or wherever, it's live streamed and we are part of it. And we are commenting on it and we're getting feedback and we are getting drawn into it. So in a sense, it's no longer just an American phenomenon. It's becoming a global phenomenon where anybody who identifies with those that are suffering in the US starts to feel like there's something they can do about it and that they need to say something about it to demonstrate solidarity. So that is probably one of the reasons why globally people of color, Black people, are getting a lot more involved in these incidents that are happening outside of Africa, even though on the African continents, a lot of similar stuff is happening, probably this time with regards to poverty and socioeconomic deprivation, but also with regard to ethnic segregation, if you like. And my argument has always been that you can have a sense of justice and have a sense of what needs to be done and what's right and what's wrong. And it doesn't stop you from speaking out against injustice elsewhere, even as you speak out against injustice in your own neighborhood. And I think one of the things that I do and that I hear Pamela talk about is figuring out what I as an individual can do, beginning locally, but even if having some impact globally would be good. And one of the important things about watching what's happening outside of Africa is that we have an opportunity to learn how sometimes not to do things, especially from the government side of things, how not to deal with people who are protesting against police brutality, how not to speak about it to the people and so on, but also in some instances, how to best deal with it so that people are given an opportunity to express themselves and people are given an opportunity to effect meaningful change, that eventually they can start feeling like they're part of the community, they're part of the system, and therefore they have some degree of control over their lives. I find that when people live in a community where they feel they have no control, that this makes the suffering worse. And this makes them even more vulnerable to a lot of the effects of the systemic violence that is built into our governance systems.
Thank you. We have lots of questions in the Q&A and limited time, but I'm gonna ask Dr. Collins and Dr. Lockman to reflect on both of these. I'll start with Dr. Lockman. I think there's a few that sort of involve the child realm. And so one, I think people are concerned when kids go back to school eventually, what will that be like with them and sort of how do we navigate sort of their social emotional well-being and the needs of the students. I think in the same vein, if you don't mind commenting a little bit on when people are in a community that may not be very diverse, and how do you then widen your circle of friends and the things you do to expose your family to diverse opportunities. And then Dr. Collins, after that, I think there's a couple questions really thinking about And this is maybe a nice way to sort of end our conversation of like, what are the next steps? We've talked about a lot of like what's happening and what's not going well, but we're going to be confronted in the healthcare system, in the mental health care system, with seeing maybe the mistreatment of people. And what do we do as providers? Medical students and residents and other trainees are sometimes involved in these situations too. And so maybe a couple of things or words of wisdom on how do we handle this to better take care of Black patients, Indigenous patients, and people of color. So we'll start with Dr. Lockman.
Yeah, so thanks. I think maybe I'll address first what happens when you live in a community that isn't that diverse. And we often get that feedback where people say, well, you know, I just give my child a better life. I live in a better community. It unfortunately is the same middle, upper class, same color skin kind of thing. I send my child to a private school or where most kids look the same. And I often would say, well, you know, children learn not just from you, but also from what resources you provide them with. And so especially in the day and age of social media and access to the internet, it's really a cop-out, I think, to say that there isn't that exposure, because you have a choice in the kind of toys you buy for your kids. Are you just supplying them with white Barbies, for example? You know, when there's a whole range of other gender neutral, but also racially diverse, culturally diverse toys, just dolls as an example. The other thing is also about books. And not just about the fact that this is the standard that children are provided with and these are the classics, but we really have to make the concerted effort, especially if you're living in a community where the every day-to-day engagement isn't with people who are different from you. Then you have to be able to pool resources. So like I've said before, there are numerous platforms which engage and try and promote authors who are people of color, who look at children in hijab, children who are Black, children who are brown. And so we need to then try and pull that together. So that's just a short answer for that. I think there are resources and we need to make a conscious effort. The thing about children returning to school is a little bit more complex because it really is about how are you feeling as the parent, once again. And we always go back to that because children are surprisingly resilient. And one of the things children have missed out the most in, I know we've had 4 months of lockdown in South Africa, has been that time for social engagement. So they've been bombarded with Zoom online lessons and extracurriculars and all kinds of things, but they haven't really had social engagement. And so they miss their friends and they miss their peers. And you will be surprised when children go back to school, they're actually quite keen. What's making them fearful is the adult's perception of what's going to happen. Who's going to get sick? How are people going to manage if things go out of hand? And so it is about making sure that you're not projecting your own anxieties on the children returning to school. Allow them that openness, but also allow for schools to engage with children in terms of what is not normal. It's not normal to go back to school in a pandemic. It's not normal to just pretend that half the year hasn't just, you know, blindsided everyone. And we have to talk about grief. The grief that comes out of loss, not just loss of people, but loss of time. And for children, this time is vital. They've lost the ability to make new friends, to learn new things at school. They feel like life has just passed them by, and it's scary. So I think that schools need to think collectively about how they have time to engage with children in terms of what's the social emotional losses that have occurred and how we frame it in a way that it's not necessarily the end of the world, even though it feels like it for the adults around there, but that children need to be able to find words and be given the assistance to find the words, that it's not okay, that it is scary, and that actually in a way they're actually glad to be back at school. So permission to do that, because I know a lot of parents are very anxious about just acknowledging that children may not be that stressed out in general.
Thank you. And Dr. Collins, some words of wisdom around thinking about what can you do as a bystander if you see something with a patient, and or just thinking about the way we provide care. I think you alluded to some of that earlier, and so sort of things that we can all do.
Yeah, that's a great question. And you know, this is an interesting time, right? There's an opening, at least at for those who are students, residents, faculty in institutions. There's an opening right now where institutions are willing to make changes, or there seems to be a willingness to do that. And I think there's also been a bit more of a sense of safety for people to actually express their own personal experiences of bias, of racism within these systems. And so I would first encourage people to take advantage of that, to take this moment to request change. If you are a faculty member who can begin to talk to your institution, do that. Bring your allies along with you. Enable it so that those people can also speak up on behalf of anti-racist activities. Get your institution to articulate plans for what it will do to address the kinds of problems that you're seeing. If this is about medical education, if it's about the lack of representation, if it's about the lack of training related to diverse groups in psychiatry, I think first this is the time to actually articulate clearly what those things are that need to happen. And be very specific. Ask for what we can do in the immediate term, what can happen in the short term, what can happen in the middle term and the long term, and see where you can get responses for that. I think this is also a time where people have to pay attention to what is happening to students, what is happening to young people who are in training and who are making their way through these systems, and how can you support them? And that might happen at the institution, but if it doesn't, the other thing that's great that's happening in this time is that people are using Zoom. People are making themselves available. Use your professional societies, right? Use the National Medical Association, use the American Psychiatric Association, use the Black Caucus and the American, use these groups who are convening webinars, who are trying to engage the community, both the non-professional community and the professional community, and make space available for trainees, for professionals to come together right now to organize and to just talk, right, and to support each other. So I think we're at a strange time, but we also, at least those of us in the professions, can reach out to others and reach out to each other in a way that we haven't been able to before. At least we haven't been focused on because we haven't been using technology. So take advantage of the technology to support each other. And I also just want to say a word about care, that this is another advantage of this time, is that people who have access to telepsychiatry, who have access to the technology, can access support groups, therapists, doctors online. What we found in Seattle, though, and have been very conscious of, is that everyone does not have access to the technology. So that, in fact, we have to do both. We have to say, you can see a provider in person, you can still do that, or you can see a provider online if you prefer to do that. But ensuring that actually we don't increase and accentuate disparities in this time of increased use of Zoom and telepsychiatry. So use technology, take this opening, try to push for what you need, and find your allies, whether that means mentors, connect with people online, connect with the professional societies. I think everyone's trying to make more resources available for people right now.
Thank you so much, Dr. Collins. And Dr. Lukoya, I'm going to give you the last couple minutes because there was one question. I think we've sort of thought about, what do we do for our kids? We're talking about our healthcare providers, students, and trainees. And I know you reflected a little bit ago about the community. And there is a question sort of alluding, how do we get out of this power dynamic between the oppressor and the oppressed, the empowered and the disempowered? And how do we think about disrupting that and building community to move forward? So I'd love for you to reflect on that.
Yeah, thank you very much. In fact, somebody was asking that we seem to have got independence a long time ago, and these disparities still exist in our countries. And I was just going to point out that a lot of the disparities are because of the structure of governance, because there was no vacuum. Even after independence, those that took over inherited a structure that was in place, and it was important, if things were going to change, to disrupt that structure and reimagine it in a way that is in line with the aspirations of the people of Africa, the people of the African countries that were then becoming independent. And this didn't happen at independence. Most of them just inherited and continued along. So if you look at the geographical divisions within the country, they are colonial. They were designed to ensure that people who look a certain way are bunched together in an area away from people who look different, and accentuate the differences rather than emphasize the similarities. And so we have kept these boundaries. And so if you think about a region, you're really thinking about an ethnicity, you're really thinking about a socioeconomic structure, you're really thinking about difference when you think about regions in most African countries, rather than thinking of them as political units for people to express themselves. You think about them as facts of almost biology, that people who look like that must be in that area, and that when they're out of that area, they are strangers or foreigners, even within the same country. So I think those of us who are interested in disrupting these power dynamics and creating more equal societies, and creating societies where people have more equal opportunities to reach their full potential, must start examining those structures that were inherited, and including structures that have been designed even in recent times, but along the same colonial structures, same colonial thinking. This is what must be disrupted. And I am very happy that many young people follow these debates. Many young people are engaged. Many young people are speaking to each other online, and they create an opportunity to try to go beyond those boundaries, to go beyond those lines, and start imagining a new humanity, a new nationalism that doesn't depend on color, that doesn't depend on ethnicity, in order to allow humans to express themselves. So I think there's a lot of opportunity, and Africa is a very young continent compared to many other areas in the world, and the youth are the promise that the future will not be the same as the past has been and the present is. Thank you.
What an excellent closing remark. Thank you very much. The youth will lead the way. I fully agree on that. And I think we're seeing it a lot, and Dr. Collins alluded to it too, and trainees and medical students and other people that are really doing a lot, at least in the healthcare system, to move institutions forward, to be less racist. So thank you all. I think this was a really rich discussion. We had lots of questions, and I'm sorry for those questions that we did not get to. We're trying to stick to time. We know everyone's time is valuable. But Dr. Collins, Dr. Lachman, and Atwali, thank you very much for your time today. I want to remind everybody that there is a survey that goes out, and we really appreciate any feedback. We want to do the next few webinars on topics that you're interested in, so please let us know and please fill out the survey. Our next webinar is actually Thursday, August 20th at the same time. It's on mental health on the front line, healthcare workers during COVID-19. So really, thinking about all of the people in the hospitals and the systems that have been impacted by COVID and their own mental health. So we'll have 3 different panelists, again, talking about their experiences, lessons learned as we move forward. Thanks again. Have a great day.
Thank you very much.
Thank you.
Yes, thanks.
Bye.
Bye.